Thanks again for a great introduction, and thank you for inviting me. I'm honored to be talking to this group of people, and I think it's a great initiative, and I'll be happy to be a part of it in the future as well. Um, I hope you can see my screen. So I'm going to talk to you about imaging of rectal cancer, and I'm going to talk about the background, some clinical background, provide a little bit of surgical options for rectal cancer, and talk about the MR protocol that is a standard of imaging for staging of rectal cancer, talking a little bit about the anatomy, about the role of radiologists for preoperative staging, and using the standardized reporting that's useful for the surgeons and oncologists. And I'll show you some examples along the way. There's no need to mention that colorectal cancer is on the rise. It's the third most common cancer globally. It's about 8% of all new cancer cases in the United States. And just in the year 2017, there was about 50,000 deaths related to colorectal cancer in the United States. Rectal cancer is a variant of colorectal cancer and has worse prognosis compared to the other types of colorectal cancer because of its location and because of a higher rate of local recurrence after the treatment. Why is local recurrence important, and why does it indicate poor prognosis? Is because that it's indicates an incurable disease and poor quality of life because of its location and because of its proximity to the sphincters and the limitations of surgery in that small area. It's been shown that preoperative chemoradiation therapy reduces risk of local recurrence. So that's where the role of radiologists would be very important for the surgeons and for the oncologists, because they want a radiologist to be able to give them enough information to locally stage the tumor and to see if they have to proceed with surgery or start chemoradiation therapy first. Okay, so in terms of surgical management, I want to introduce a few terms and define a few terms that is radiologists need to know about. You will hear in the literature or talking to your surgeon colleagues, you'll hear term TME, which is sorry. Okay, you will hear the term TME, which is total mesorectal excision, which is considered the standard of treatment for patients with rectal cancer. And what it means is it means that the surgeon removes the entire rectal compartment along with the surrounding mesodermal fat, and along with the other planes that are confined to the mesorectal fascia. What is mesorectal fascia? I'll show you more in detail on images, but mesorectal fascia, or MRF, is a fascial plane that surrounds the rectum, and it surrounds the mesorectal fat. And you can it's a radiological term, and it's actually an anatomical term that you can see well on MR. CRM, on the other hand, is a pathological term. If you look at a surgical report or pathology report on a rectal cancer case that was excised, you'll see basically the CRM is used, and it's actually corresponding to the rind or to the soft tissue plane that was surgically dissected. And usually the surgeon wants to use MRF or mesorectal fascia as the as the circumferential as the circumferential resection margin, which basically what CRM stands for. They want to approximate that line of dissection to the mesorectal fascia. So you'll hear CRM using interchangeably on pathological reports. And why is it important? Because based on the pathology report, you're going to hear if the surgical margin was positive or negative. And what they're talking about is basically they want to see if this circumferential resection margin, CRM, is more than 1 millimeter from the tumor on histology after surgical resection. So if that happens, they're going to say the surgical margin was negative, or CRM, or circumferential resection margin was negative. If it's involved by tumor, if the tumor exceeds that 1 millimeter and is very close to the cut edge on histology, they're going to say it's either, they're going to use term like R plus or R1 or R2, R1, meaning that it's just histologically the cells of the tumor are very close to the resection margin, and if it's R2, it means that the gross specimen shows that the tumor is invading the CRM. So just a few pathological terms. Okay. Sorry, I'm just some mouse malfunction. Okay, so there's different surgical approaches to the rectal cancer. The more standard one that's used for high rectal cancer, and we talk about what high rectal cancer means, is low anterior resection. And basically what they remove is they remove the entire rectum, a little bit of the sigmoid colon along this dotted line, and actually they extend into the mesorectal fascia, and like basically resect this portion of the rectum along with a little bit of fat. And this fat on coronal plane, if you look at on axial plane, you'll see the MRF. So they're resecting along the mesorectal fascia, but they don't touch the external sphincter, which you can see here, the levator muscles, and they don't touch the internal sphincter, which is a continuation of the muscularis layer of the rectum. So they don't touch that. So they reserve this for the high rectal tumor. For the mid rectal tumor, which is like usually it's a little bit lower, if the tumor has not invaded the sphincters, they might consider doing the ultra low LAR, which is actually the extended resection margin a little bit lower, but not touching the internal sphincter, or they do intersphincteric abdominoperineal resection. And so what abdominoperineal resection is basically for low rectal tumors, they do two-part surgery. They do a little bit of surgery in the abdomen. They resect, again, the rectum intra-abdominally with a little bit of mesorectal fat and fascia. And then they do a second part of the surgery from the perineum. They resect the sphincter and the anal canal. If it's possible, if the tumor has not invaded, again, into the levator muscle to the external sphincter, they're going to keep that, and they're going to dissect along the intersphincteric fat along this dotted line again. So that's called intersphincteric APR. For the low rectal tumors that are meaning that there is a higher chance of involvement of the internal sphincter or musculature, external sphincteric musculature, or the levator muscle, they're going to take out the entire thing, and the patient is not going to be continent. Basically, they're just going to lose the sphincteric function. And again, you're going to see the resection margin involves all the muscles. Okay, what's the role of imaging? We use commonly CT or PET-CT for staging, and similar to, we're just going to do chest, abdomen, pelvis CT or PET-CT to exclude distant metastases. And how about local staging? So do we have a staging just for excluding metastatic disease, and then we have a second stage in which actually indicates prognosis by using either EUS, which is endoscopic ultrasound, that's something that usually the surgeon does, or a radiology assistant in this matter would be doing an MRI for doing local staging just to see how big the tumor is. What's the advantage of doing a rectal MR? Obviously, you're going to be able to see the treated margin. If you're going to identify the mesorectal fascia, you're going to identify the peritoneal lining, and I'll show you examples of that. And you're going to indicate to the surgeon that some of these margins are involved, and then indicate that like they need to do the CRT, chemoradiation therapy beforehand. You're going to decide, obviously, if the surgery would be the first hand or we need to do the preoperative CRT, as I said. And there are some prognostic features that are important, including the looking at lymph nodes, looking at presence of invasion of adjacent structures, and also something that we call extramural vascular invasion. And I go into the detail what that indicates. It basically means the tumor has extended into the vasculature, and it's actually the risk of metastatic disease is higher and it has a poor prognosis. And then you're going to decide, you're going to, by the information you provide on MRI, the surgeon will decide if they're going to proceed with total mesorectal excision or do low anterior resection, or if they need to extend it to the APR, abdominal perineal resection, and if the sphincteric mechanism was involved and they need to spare that. What is endoscopic ultrasound? It's similar to any other ultrasound they do on upper GI, on endoscopy, or through the rectum. Basically, this is an example of the picture that you see from the literature. You're going to see it has a good resolution to identify different layers of the wall of the rectum. And it kind of reminds me of a Big Mac. And what you see as a dark band here, the two different dark bands here, it corresponds to two different muscularis layers, which is corresponding to the patties on the Big Mac. And then the lines that are wider or echogenic, they are the ones that contain either fat or mucosa. So this is a mucosal layer. This dark band is a muscularis mucosa layer, is a kind of a muscle underneath the mucosal layer. And then the third layer is submucosa, which is again white. And then you have a muscularis properior level, which is very important in our identification of the treated margin. And then we have a serosal layer. So just keep in mind these 5 layers that are common in everywhere in the GI tract, but pay extra attention to the muscularis properior layer, and remember that I'm going to show you this on MR and how it looks. When do we do endoscopic ultrasound? If the tumor is a pedunculated tumor or is in the early stage tumor, basically T1 or T2, if the tumor is only as a pedunculated polyp here, or is involving only these 2 layers, endoscopic ultrasound has a better chance of differentiating these 2 tumors. The application of MR, on the other hand, is when the tumor is more advanced and they cannot see the other layers. The endoscopic ultrasound is not that useful. So if it's involving or getting close to the muscularis properior level, they're gonna do MRI because the US doesn't have a good resolution to exclude involvement beyond the muscularis properior level. It has a small field of view. It has a lower accuracy for detecting lymph nodes, and usually you cannot differentiate fibrosis versus tumor on endoscopic ultrasound. And again, when the tumor is too high and it gets close to the sigmoid, rectosigmoid junction, it doesn't have that much of good resolution for that. Okay, so let's talk about MRI. We're going to, at the standard protocol, we are going to use high-resolution T2 weighted images on axial, sagittal, and coronal plane, basically triplanar high-resolution T2 weighted imaging. We have a smaller field of view because we want to have a higher resolution. The slice thickness usually is as thin as possible. Sometimes we use a 3D T2 sequence, which is in our practice, we don't think this is very useful because this T2 space has a higher resolution, but doesn't have a good contrast. This is a 3D T2 weighted image. It's called space on Siemens scanners and Cube on GE scanners. In our practice, we don't use this. In a lot of places they use this, but I think it's not as good as doing the high resolution T2. So what do we do? So how do we prescribe these planes? Obviously, the technologists will acquire this sagittal plane, and then once you see the rectum all the way to the anal verge, you're going to identify where the tumor is, and then they're going to subscribe a plane perpendicular to the where the tumor is located, and that will be your axial. So we have the sagittal, that will be your axial, and then coronal, again, perpendicular to that would be your coronal plane. Definitely we are going to use DWI because for restaging is very important. For assessing response to treatment, the diffusion weighted imaging is very important. We're going to use multi-phase post-contrast series as well. And in some places, they prescribe glucagon as an antiperistaltic agent. But again, we are not using that. One thing that's very useful, and I didn't include in this image, is actually administering rectal gel, because as you can see, this is an older slide. If you administer gel, the rectum will be more distended, and you're going to see the tumor much better, and you're going to see which walls are involved. And then in our practice, we are now using rectal gel for all rectal cancers. On the T2 coronal, if you want to look at the anatomy, on the coronal plane, you're going to see the levator muscle beautifully seen on both sides. I hope you can see my my pointer, or maybe I just change it to something better. 1 second. Okay, so if you can see my pointer, I'm pointing out the levator muscles on the coronal plane, and then we are gonna. Sorry, 1 second. Sorry, I have some malfunction here. 1 second. Okay. I hope you can see my screen. Hello?
Yes, we can see.
Okay, wonderful. Okay, sorry about that. I had some malfunction. Okay, so let me go back to the laser pointer. Okay. I think I shouldn't use the laser pointer. Okay, so we see the levator muscle here on both sides. And then after that, we're going to see the puborectalis muscle. So these muscles are aligned with each other. The one that has a V-shaped structure is a levator ani muscle, and then the puborectalis is towards the mid-rectum, mid to lower rectum, and it's actually on the axial. You're going to see it's creating a sling around the anorectal junction, and I'll show you on sagittal again. But the muscle that connects to the posterior aspect of the pubic bone and just makes a sling around the rectum and creates an angle in the anorectal junction is puborectalis, so it's in the mid portion again. And then we have this external sphincter, this dark band here. And then beautifully, you can see this white stuff, which is intersphincteric fat, and whatever that is inside, that's along the course of the muscularis layer, which is this, again, dark band here. You're going to see the internal sphincter. And I forgot to show you on the axis, so I haven't reached that slide yet, but basically I'm going to show you the muscularis layer. But remember, this internal sphincter is in continuity of the muscularis layer, and then we are going to see intersphincteric fat, which is this white band in between the internal and the external sphincter. This is a very nice pathologic slide from this paper that they show you like why we talk about upper rectum, middle rectum, and lower rectum. In the upper rectum and which is close to the sigmoid colon, you see a big portion of the rectum is actually covered by peritoneal lining. So when we talk about high rectal cancers, we don't talk too much about the mesorectal fascia because mesorectal fascia is only here, and the rest of it is the peritoneal lining. And if the tumor is involving the peritoneal lining, it will be stage 4 because the peritoneum is involved. But the more you get close to the middle and lower rectum, you're going to see this dark band, which is actually the mesorectal fascia, and it's extraperitoneal. In the mid-rectum, usually you have a less amount, like usually about 30% of the rectum anteriorly is covered by peritoneum. I will show you what the application of that is. Okay. Again, go back to the T2 coronal and the structure I just showed you. This is a peritoneal reflection, which is on T2 coronal plane. You can see as a V-shaped structure again. And in a male, you're going to see this is very in a close contact with the seminal vesicles. So you can see this appearance here. And on the sagittal, again, this is a high resolution T2. You're going to see this dark band of tissue. I hope you can see my pointer. This is actually muscularis layer. And then right outside of that, you're going to see the mesorectal fat. So this is a point of distinction on MR. We want to see a tumor is confined to this layer. If it's invaded, this layer is invaded, we have a T3 stage tumor. And depending on the depth of invasion into the fat, we are going to have either early T3 stage or late T3 stage. What other anatomical structure that's important? This is anal verge. Basically, this is where the columnar and squamous cell histology of the mucosa changes from the anal canal into the basically to the skin. And why is it important? Because this is a point of reference for the colonoscopist and the surgeon to say, like, for example, they see a tumor somewhere and they say this tumor is like 10 centimeters from anal verge on the sagittal. You have to be able to identify that structure and then make your measurements as you go above. This is the anorectal junction I was talking to you about, and this is on sagittal plane. This is where the puborectalis extends and makes a sling around the rectum, and that would be the anorectal junction. So below that is the anal canal, and these are the sphincters, and this is the rectum. And so that's the anorectal junction. And why is it important? Because, you know, the more tumor is closer to this area, you're going to see higher rate of involvement of the sphincter mechanism and sphincters. And then we consider these tumors that are lower, we call them low rectal tumors, and they have a higher risk of recurrence, and the surgery is harder, and then usually they undergo APR. Where's the peritoneal reflection? As I said, this is the prostate gland, and then this is the seminal vesicle. You see it on the sagittal plane, and then you see this dark line that's covering the rectum anteriorly. That's where usually if the patient has ascites, you're going to see a little bit of fluid in this reflection. And so this is a peritoneal recess or peritoneal reflection. In a female, this is a place that the recto-vaginal or recto-uterine recess is, and you're going to see this as like usually when you see fluid collection in the pelvis is located in that area. On axial plane, you're going to see beautifully as a donut, this is the rectum. Usually this mucosa and submucosal layer are not as well differentiated on MR, and that's why we call it mucosa submucosal layers. You see these like, you know, dark and bright stuff, and then we don't see much else, and we see this dark band outside of it, which is a boundary of this circle or donut-shaped structure, and that is the muscularis proprior layer. And anything outside of that would be the mesorectal fat, and then this is the mesorectal fascia. And what is this fascia? Again, this is a extraperitoneal lining. So peritoneum is not here yet. We're lower. We're in the mid-rectum now. We haven't reached the peritoneum anteriorly. So that line shows you where the mesorectal fascia is. And why is it important? Because during the mesorectal excision, they take out the entire plane of tissue around it. And when the tumor comes out of this dark band, it will be a T3 stage tumor. And once it involves the mesorectal fascia, then there's a high risk of recurrence. So that's why identification of that this structure is very important. In the rectoprostatic portion, this fascia has a different name. It's called rectoprostatic, or the non-Weir's fascia. It's just an anatomical term. Okay, this is an example of on a regular MR how you see the peritoneal reflection. This is a little bit of trace fluid inside the peritoneal cavity, and you can see this appearance of. You can see a lot of. Can you hear me well? I saw a message that says my voice is not.
I can hear you.
Okay, you can hear me. Okay, perfect. So again, this is at the level that we are higher. This is a high rectal level. We see the mesorectal fascia posteriorly, and anteriorly we see this peritoneal reflection. So remember, when we say there's a tumor sitting here or the tumor sitting here, if the tumor goes into the peritoneal reflection, that would be a T4 stage tumor. But if the tumor is just sitting here, it would be T3 stage if it involves the mesorectal fascia. The differentiation is very important because in a high rectum, because peritoneum, when a tumor reaches the peritoneum, it can extend everywhere in the peritoneal cavity. So, and then you can see this fluid collection gives you this seagull appearance. It almost looks like a seagull. So try to find it and locate this on any regular MR or CT that you're reading. Okay, so once we know the anatomy, once we know what sequences we're going to use, we're going to localize the tumor. As I said, we're on a sagittal plane. We are going to find the tumor, and we're just going to measure the distance of the lower border of tumor from the anal verge. And based on where it's located, if it's between 0 to 5 centimeter, we call it low rectal tumor. If it's 5 to 10, it's mid rectal, and it's 10 to 15, it would be high rectal tumor. You're going to talk about distance from the anorectal junction. Why? Because we want to know where the sphincter is. So basically, the location of this tumor from the sphincter. This is the sphincter around here. And if the tumor is located here, we want to measure that distance here. This is the anal verge down here. Now, the length of tumor, we want to know how much the tumor expands. Is it like 2 centimeter, 3 centimeter? How long is the tumor is? And circumferential location. What's our, like, for example, is it like half circumferential? Is it only 25% of circumference? Or is it 100% of circumference, or 360 degrees of the circumference? And then we're going to say it's from 1 o'clock to 3 o'clock, vice versa. A relationship with sphincter, we talked about that, and the location and the relationship with the intersphincteric fat. Talked about anterior peritoneal reflection. This is important. Some rectal tumors are mucinous, and they look T2 bright. So basically, they produce abundant of mucin, and that's why they're important. In restaging, it will be important because you have to differentiate some T2 dark tumor from the mucin that was produced, and it's just leftover mucin. We're going to talk about, I'm going to show you some examples of invasion into the mesorectal fat, basically invasion beyond the muscularis layer. And we're going to talk about how far it went into the mesorectal fat. So that will be T3 stage early or late. And then we're going to talk about maximum depth of invasion. Is it below 5 millimeter, more than 5 millimeter, and the shortest tumor distance from the mesorectal fascia and the levator muscle. I'm going to show you examples of all of that. We're going to talk about the lymph nodes and then presence or absence of extramural vascular invasion. So in a standard report, we are going to talk about all of that. So tumor localization. So distance from the anal verge. So we have a tumor. We want to see where this tumor is located. Okay, if it's between 0 to 5 centimeter, we will call it a low rectal tumor. And if it's between 5 to 10 centimeter, it's mid-rectal, and above that is 10 to 15, it will be high rectal. Remember, beyond 15 centimeter from the rectum, it's not actually a rectal tumor anymore. It's actually sigmoid cancer. Some people mistakenly say like, oh, there's a rectal tumor here. No, there's no rectum there. If it's 15 centimeter beyond, it will be a sigmoid colon. If you don't know, it's close to this junction, you can call it a rectosigmoid cancer. But again, it would be more in the territory of sigmoid colon because the peritoneum ends here. Why is it important? Again, the length of tumor is important because the different types of surgeries are used. For high rectal tumors, we do low anterior resection. For mid rectum, we do LAR, ultra low LAR, or intersphincteric APR, and then for the low rectal tumor, we do the APR basically, or usually they take out the entire perineum. And then we talk about clockwise manner. Is it anterior, posterior, right, or left? T1 and T2 stage, we can't differentiate much on MR. I will show examples of that. So we're going to say there's a tumor, it might be T1/T2 or a T1 or T2. Doesn't matter. The surgery would be the treatment of choice for this because it hasn't extended into the muscularis layer. If the invasion is present into the mesorectal fat, then it would be a T3 stage. At this point, we are going to do the chemoradiation therapy for these patients to make sure hoping that by doing this chemoradiation, the tumor shrinks, and then the surgeon later on can take out the entire rectum. We're going to say how far it went into the mesorectal fat. And T4 stage is reserved for if there's an organ invasion. And remember, if the peritoneum is involved, it's a T4A stage. And if it's involvement of any other pelvic organs, it will be a T4B stage. You're going to talk about N0, N1, and N2. N0 is no regional lymph node. N1 is 1 to 3 regional lymph nodes, meaning that mesorectal or extramesorectal lymph nodes. And then N2 is more than 4 lymph nodes. And then M1 and M0 is basically presence or absence of distant metastatic disease. Okay, let's look at some examples. This is a patient who has, again, there's no rectal gel, so it's making it a little bit hard, but you can see there's a tumor sitting here, about in a mid-rectum, and then you see it's confined to this dark band. So, and you can see it on a post-contrast, it's enhancing. This is an artifact, there's no extension, this is actually a vessel. And then you can see around it on the T2, there's no extension beyond. So we call this T1/T2. This turned out to be a T1 stage. It was resected. Look at this space sequence for another rectal tumor that's sitting right there. There's a lymph node in the mesorectal fat, but we don't see obvious extension beyond the fat. So you can see this C-shaped structure sitting in the rectum. This dark band is the mesorectal, the muscularis layer. This is there's no tumor going beyond into the mesorectal fat. This fat is clean, and then this is a diffusion weighted imaging that's showing this C-shaped structure. So this turned out to be a T2 stage. Again, we cannot differentiate it. We just say T1/T2. They're gonna go to surgery. This is another tumor that's pedunculated. It looks like there's a tubulovillous adenoma type of thing that has turned into a cancer. It has a stalk. You can see the stalk. It is mucin producing. That's why it's T2 bright. You can see it on coronal. It looks like a tree, almost like a fern. And then you can see this tumor is extending to the lumen of the rectum, and it just shows a little bit of centrally not much, but peripherally it has enhancement. This turned out to be not extending beyond the mesorectal fascia, so it was, mesorectal into the mesorectal fat, so it turned out to be a T2 stage tumor. Okay, so when you're dealing with a little bit of irregularity of the mesorectal fat, it's very hard to differentiate between actual tumor cells that are extending into the fat, or when there's a tumor sitting right here. This is a little bit dark, so hopefully you can see it well. But there's a tumor sitting right here, and then there's a dark band coming out of it. Wherever there's a tumor, there is some fibrotic reaction, some perirectal or peritumoral fibrosis. And peritumoral fibrosis is usually dark, as opposed to the actual tumor cells that are T2 bright or T2 intermediate. We call this Evo gray. And it looks a little bit nodular. So it's hard to differentiate peritumoral fibrosis from early T3 stage. And that's actually okay, because there's not much of difference between the management. If the patient has an early T3 stage, usually they proceed with surgery. And as opposed to, like, patient who has a peritumoral fibrosis, it's a T2 stage. So traditionally, we used to say this needs CRT, this needs surgery, but nowadays, a lot of early T3 stages are being referred to surgery because their actual prognosis is not that much different. And if you are not sure, you can actually say it's either T2 versus early T3. And the surgeon will understand that we usually have multidisciplinary conferences, and the oncologist is sitting there, the surgeon is there. So we tell them that it's hard to differentiate between the two, and they understand that they are going to look at the patient's profile and just either proceed with CRT or surgery, but usually they can do surgery with early T3 stage. This is unequivocal tumor that is extending beyond the wall. It looks nodular, so there's no doubt here that there's a T3 stage tumor sitting here. This is a large tumor sitting here. Again, the plane is a little bit off because I wanted to show you this nodular appearing. There's a lymph node sitting here, but then there's a nodule coming out. And then this is a diffusion-weighted imaging showing corresponding to that area. So what you do is, this is a muscularis layer. You're just going to measure the distance that the tumor has come out. So that will be like, is it below 5 millimeter, above 5 millimeter? And that will be important for the prognosis. So why is it important? Because early versus advanced T3 stage has a different prognosis. If it's below 5 millimeter, 5-year survival is 85%. If it's beyond 5 millimeter, it drops to 54%. So that's why it's very important to do chemotherapy, radiation therapy first for this, and then maybe they can just proceed with surgery with their early T3 stage. Something else that's important is the distance of tumor from the mesorectal fascia. As you can see, I'm showing you here. And basically, we are going to talk about distance in our report. If the tumor has extended into the mesorectal fat, how far it went into the mesorectal fat, and then how far is the tumor from the mesorectal fascia. And when this patient undergoes surgery, the report of the pathology comes back and say, the circumferential resection margin is more than 5 millimeter from the tumor. So that's good. It means that this patient has better prognosis. On the other hand, this tumor has come and invaded into the mesorectal fat. And see, this is this dark band. This is actually your mesorectal fascia. So it's invaded into the mesorectal fascia. So if this happens, the CRM is 0. So then at that point, maybe the resection margin is positive. This patient definitely needs chemoradiation afterwards and beforehand as well. Based on 2 different publications, says if the MRI is beyond, if on MRI the CRM is about 5 millimeter, the PAT, it's an indicator that on pathology we are going to have a negative margin. But in other publications, it says like if it's beyond 1 millimeter. So I think if the tumor gets very close to this mesorectal fascia, you have to measure this distance and just say it's 1 millimeter, 2 millimeter. You have to report that, because that will be an indicative of positive or negative margin. This is another tumor. You can see this tumor is extending outward. This looks very irregular. And I will stop that, and I will show you on the coronal. You see there's a lot of tumor cells or tumor is coming out, and actually is involving the peritoneal reflection. This is a peritoneal reflection. Sorry, I cannot stop that. Apologize. So yeah, so you can see this tumor is involving the mesorectal fascia, and if you go back to the axial, you can see this tumor is involving the location of the where the peritoneal reflection. That seagull appearance is involved. How does it look if the tumor involves beyond that? So this tumor has actually involved this the right-sided levator muscle, you can see here. And actually on the axial plane, you can see it's invading the vaginal cuff or anterior vagina. So this patient is a T4B stage. If it's involving the peritoneum, it's T4A. It's involving the surrounding structure, it's T4B. This is another cancer that's locally advanced. It's involving the left ovary. It's involving the uterus, posterior uterine wall. So this was a T4B stage. This is the same case. You can look at the uterus and is involved by the tumor, and also on the same side, you can see the ovaries involved. So that's a T4B stage. This is another case that look at this bowel loop. This bowel loop is invaded by a very large tumor, and it's causing bowel obstruction. Again, you're going to see it here. There's a bowel loop here. There's involvement of a bowel loop, and this patient right there has a closed loop obstruction because of that. And also the patient not only had involvement of this bowel loop by the tumor, it's actually also involving the bilateral uretrovesical junctions, and there's hydronephrosis associated with that. So this is a T4B stage. Okay, so what is extramural vascular invasion? Again, there is discrete tumor inside a vessel. Discrete serpiginous and tubular intermediate signal projection into the mesorectal fat. So if you see in the mesorectal fat, there's something that looks like a tumor that's involving and coming out, and is linear. It's suggestive of extramural vascular invasion. What is important is an independent poor prognostic feature. Look at these two graphs. These patients did not have extramural vascular invasion. These patients had extramural vascular invasion. So see the significant drop of the survival after, these are months, so they die sooner. There's increased risk of metastasis. Obviously, when the tumor is almost like a tumor thrombus, tumor goes into a vessel, goes directly into a peritoneal, goes into the portal system and goes into the liver. And then decreased free survival. And MRI is, if you see it, is highly specific, but it's not very sensitive. I will show you examples. So this is actually the tubular branching structure that's coming out of the rectum. That's actually extramural vascular invasion. You can see it on axial plane here. On sagittal, you can see it almost, and you have to be able to scroll to see that dark band coming out. Okay, so, sorry, I cannot stop this video, but there's a large rectal cancer here. And then look at the superior rectal vein. See, there's a tumor within it. You can see it better on, so this is a tumor. This is a mucinous tumor. You can see it on CT actually extending outwards significantly. And then it gets very close to this vessel, and then you see a tumor inside this vessel. Usually you don't see it on CT, but in this case, we were able to see it on CT. So that's how extramural vascular invasion looks like on CT. We talked about low rectal tumors, which is tumors that are located from 0 to 5 centimeters from the anal verge. They have a higher positive CRM, or circumferential resection margin rate, so basically positive margins, because there's a very narrow space that this tumor extends to, and when they try to excise it, they're going to have positive margin. Remember that sometimes we have anal cancers that arise that are squamous cell carcinoma, not adenocarcinoma, and they look very similar to low rectal cancers, but we never use rectal MRI template. They have different staging and treatment protocol. So again, for the low rectal tumor, if the tumor is confined to submucosa T1, if it extends only to the internal sphincters T2, if it extends into the intersphincteric fat, it would be T3. This intersphincteric fat is actually the extension of the mesorectal fat. So remember that when it invades into the mesorectal fat, we call it T3. Here, there's a very narrow space of fat, so we call it a T3. If it's that fat is obliterated or gone, and then if it involves external sphincter and beyond, it will be a T4 stage. You can see there's a low rectal tumor on axial plane. See, this is a dark band. This is healthy. This is unhealthy. This is intermediate signal. And then you can see this, mesorectal fat on this plane a little bit is asymmetric compared to the other side. So it was very suspicious for early T3 stage. So this was confined, confirmed on surgery. This is another low rectal tumor that was extending into the intersphincter fat. And this tumor was sitting here. After CRT, it was hard to differentiate, but it was like, it looked a little bit better, but still unsure if it was undergrade or not, or we can understage it or not. And then the patient had underwent APR, and it turned out to be only T3 stage. The rest of it was fibrosed. This is another sagittal case. You're going to see this, intermediate signal tumor sitting here. You can see a little bit of asymmetry on this side. See, this is a tumor right there. And then there's some asymmetry into the intersphincter fat, but also it looks like the external sphincter is a little asymmetric. See, this side is healthy, it's dark, this side is intermediate. So this was actually on diffusion. It turned out actually this is a location of the external sphincter and has abnormal signal. And this is the ADC corresponding ADC map. So there was infiltration of external sphincter. The patient had low-lying or low rectal cancer T4 stage. The patient had their APR, did well afterwards. How about end staging? So end staging is low or inferior to the T stage because in terms of prognosis, but still we're gonna, in the same MR report, we're gonna provide the end stage. Remember, size does not predict benignity. So this is an example of a abnormal mesorectal lymph node. But remember these three factors. So we are gonna look at the size of a lymph node. If the lymph node is more than 9 millimeter in short axis, is abnormal. We're gonna call it abnormal. If it's between 5 to 9 millimeter, you need to have two of these features to call it abnormal. Either has irregular borders or very speculated borders, or which you don't see here, but either internal heterogeneous signal, which actually you see here. So this is an example of heterogeneous signal, and then the round shape. If you see a round shape, that would be only one feature. So if this lymph node is between 5 to 9 millimeter, because it has two features, it will be abnormal. If it's below 5 millimeter, it needs to have all three features to be called abnormal. And then we are going to look at the mesorectal fascia or lymph nodes, and then we're going to look at outside of mesorectum. So we're going to, for the high rectal tumors, we're going to look at the along the course of middle rectal artery, along the internal iliac chain, obturator lymph nodes, median sacral, like the ones that are in front of the sacral bone, and external and common iliac lymph nodes. And then we're going to look at the non-regional lymph nodes, which are considered metastatic, which would be like, in case of like para-aortic lymph nodes or inguinal lymph nodes. And inguinal lymph nodes are metastatic. Remember that in rectal tumor. And that's actually the drainage pattern for the high rectal tumor, which usually, number A, you can see here, the lymph nodes actually go all the way to the superior rectal chain or middle rectal chain, and then go all the way to the peri-aortic area. And then this is B, which is a middle rectal tumor, and the C is inferior or lower rectal tumor. So C goes to the inguinal lymph node. So that's the way the lymphatics drain in the low rectal. So it's low rectal goes to the inguinal, A goes to the peri-aortic, and the middle or mid rectal tumors go to the internal external iliac chain. So remember that drainage pathway. Okay, so after the chemoradiation therapy, the role of radiologist is to reassess the tumor. The patient comes back after chemoradiation, so you can see in this example, there's a very large circumferential tumor. It's very abnormal in signal, and posteriorly the wall is invaded. The mesorectal fat is invaded, so it's this 3-3 stage. Unclear if this is a lymph node or like abutment of the mesorectal fascia. But then after surgery, looks how the signal improved. It's just the tumor is essentially replaced by fibrosis. So this is a favorable response. So we're going to downsize the tumor. We're not going to say this tumor is now T2. We're just going to say this was a previously T3 stage tumor, now has a complete response. So that's how our dictation is. We're not going to say, oh, now it was T2. No, we're not going to say that. This is actually undergoing treatment. So we're going to say this patient is a known T3 stage after chemoradiation therapy, has a favorable response, have a good response, basically. It's not, MRI is not super accurate for TC staging because there's a little bit of difficulty to differentiate fibrosis from the actual tumor. Because as I said, desmoplastic reaction fibrosis could be very similar to the tumor, but remember, we use DWI, and in this case, DWI is very useful. See, this is a pre-op prior to chemoradiation. You see there's a diffusion restriction, and after that it's gone. So this is favorable response. This is against on sagittal and then on sagittal after treatment. So essentially the entire thing is gone. So this is a very good example of treatment favorable response. So definitely use the diffusion weighted imaging to differentiate from the tumor from the fibrosis. So I hope I was able to talk about, give you some details about the value of MRI for local staging of rectal cancer, talk about the anatomy. Again, in summary, assessment of the role of radiologists is the assessment of the circumferential resection margin. Basically, the surgeon wants to know if the line of resection is infiltrated by tumor or not. And if there's a chance that the CRM is infiltrated by tumor, they're going to proceed with CRT as opposed to surgery. So your role as a radiologist is to assess the circumferential resection margin, or basically mesorectal fascia. Remember, for low rectal cancer, always check the sphincter, always check the intersphincter fat, and always check for that little space that is between them, which is easily the tumor exceed from T3 to T4. Remember, EOS is done only for T1 versus T2 stage. Remember, on radiology, we care about T3 stage, how deep the T3 or how far the tumor invaded into the mesorectal fat. We report that number. We record the tumor extent from the CRM, how far it is from the CRM. And then remember the structured reporting. We have to talk about, and we actually use one of the templates that have all these all these descriptions, and we go down the line and just report every single piece of information I gave you. So that will be very important for the surgeon. And then when the patient comes back after chemoradiation, we're going to say if the patient has a response or no response. I hope you was able to provide some information about rectal tumor, and I'm happy to answer any questions. Thank you.
Thank
you, Dr. Amir. That was really a wonderful talk, very elaborated and very illustrative throughout, from the protocol to staging to restaging. And I fully agree about using a structured template, which kind of gives you a checklist also. I have a question from one of our audience. How do we differentiate a residual tumor from fibrosis using DWI? I'll be glad to have an example of that, if we have an imaging example of that. Thank you.
Sure. Thank you again. That's a very important question. I would say that would be one of the challenges of restaging, local restaging MR. It we for answering that question, we definitely need good quality diffusion weighted imaging. Have you seen this example? Unfortunately, because we have like different types of scanner, sometimes it's not accurate to report a number on ADC map because from one scanner to the other, the ADC number changes. So basically, we just definitely we have to see the baseline imaging, and then qualitatively we look at the preoperative or pre-treatment scan, and then compare it to the post-operative post-treatment scan. And in this example, you're going to see, so always there's some structures on the DWI that are bright. Look at the, for example, the lymph nodes, and then have an internal reference and just see, oh, this tumor is as bright as lymph nodes, so it's showing diffusion restriction. But after the treatment, the structures that are usually bright on diffusion weighted imaging, look at lymph nodes, for example. This lymph node that not necessarily is abnormal, but they're bright, and this tumor is essentially gone, and you can't see it at the same level. You can see the sacrum here, you can see the sacrum. So basically, this is gone. So this is a qualitative assessment. This is not quantitative assessment. Basically, if I see a little bit of tumor is gone, but a little bit of tumor remaining, I just say incomplete response, meaning that there's a little bit of viable tumor still there. So the assessment would be more qualitative, and you definitely need to have the baseline imaging. I hope I was able to answer your question.
Yeah, that was quite clear. I have another question for you, Dr. Amir. How regularly do you use gadolinium in MR staging?
So based on what I showed you, there's not much of need for gadolinium for local staging, but since we do abdomen pelvis MRI, because our surgeons want to always look at the liver, and for the liver we need to have a gadolinium, we always give IV contrast or IV gadolinium, because we want to look at the liver and the abdomen and look for distant metastases. If you're only looking at the rectum, it doesn't add much to the evaluation of the rectum. The mainstay of MR, rectal MR staging, is a very good T2 weighted imaging in 3 planes. And remember that the plane should be perpendicular to the tumor, because if you look at, if you do a regular plane like that, then you're going to overcall the T stage. It should be always perpendicular to the tumor along the axis. So if you have a good T2, high resolution T2 quality, you don't need much of post contrast imaging, but we always give it because we do abdomen pelvis. And also, if you're evaluating the bone marrow, for example, sometimes, I mean, there's a chance that there's a bone lesion. So having contrast sometimes helps, but just for the case of rectal cancer is not super useful. Again, T2 is important and diffusion is very important.
Since you talk about the perpendicular plane to the tumor, it means that when you do the scout MR, and then if the tumor is not sit exactly perpendicular to the axial, coronal, or sagittal, you have to scan a little bit oblique coronal, oblique sagittal. Is that the way to scan it, or we just go ahead and do axial, sagittal, coronal?
That's a good question. So the way we do it, so when the patient lies on the scanner, they do the scout view. So scout views are usually, T2 HACE or SSFP or something like that. It's just very quick. They see the rectum. The first thing that the technologist does is sagittal. So sagittal is always the same. Always they do sagittal. We don't change the sagittal. So the first thing they acquire is a sagittal plane. And then they send this to PACS. We see this, and we put a line where the tumor is. And remember, nowadays we do rectal gel, so we see this tumor better. And then we see the tumor, and then we save an image to tell them, oh, this is a tumor. Prescribe the axial through along this axis, and they proceed with that, and then they do perpendicular to that. That would be coronal. So first scout, then sagittal. Sagittal is standard. We don't need to intervene with the sagittal. That's going to take a long time if they do all all three planes, because this takes like 2-3 minutes. If they acquire the axial and then we tell them do another axial, it takes longer. So that wouldn't be very time sensitive for we need to be out of scanners earlier on. So we just do sagittal and then axial.
Yes. To finish one study, how long does it take?
Usually the time slot that we have for if it's only pelvis, it's definitely below 20 minutes or 25 minutes.
That is so fast.
Yeah. But if you have a liver also, because it might go into the 35 minutes or so. They usually start with this. They go look at and then they do pre-contrast pelvis, and then they do the dynamic phase, the pre and post contrast of the liver, and they come back to the rectum to do a post contrast as well. So it's about 35-40 minutes.
You mentioned about the rectal gel. Is it the same like ultrasound gel, or any gel we can use? Is the specific rectal gel that you use?
Actually, that's a good question. Early on, when we started doing this, we didn't know if the gas bubbles inside the ultrasound gel might intervene or cause artifact, but actually it doesn't. It just the expense, whatever that's less expensive that you use here. The ultrasound gel is actually ideal if you can use it, but some places have either use a certain brand of gel that is used for vaginal gel or rectal. So similar to dynamic pelvic floor studies, they put gel inside the vagina and also inside the rectum. That's the same type of gel. There's nothing specific about it. It's just it's just expense. Some of them are more expensive. Some of them are less expensive.
You show one image that I remember. You talk about early T3 and the tumor fibrosis. That is, we should be able to differentiate these two, because one will be surgery and one will be chemorad.
Correct. So I was trying to put emphasis on. So see, this one has a very intermediate evilish T2, and then you see this nodule that's coming out. That's actually, if you see that, you call this T3 stage. But sometimes you don't know if this is there's a little bit of tumor here, and then there's a band here. So you don't know if this is contiguous with tumor. Is this dark band? Is it desmoplastic reaction? So if you see nodularity, we call it tumor. If you see intermediate signal, we call it tumor. If we see linear lines only and T2 dark, we call it fibrosis. But if you're not sure, it's okay to call it T2/early T3, because both of them have the same treatment. Nowadays, it's been shown that the early T3 doesn't have that much of benefit from the preoperative neoadjuvant therapy. So that's okay to do surgery in this one. They're going to decide. You say T2 versus early T3, They're going to decide. The surgeon is going to decide. And then, however, if you see this is definitely T3 stage. If you see this, so this is early T3, this is advanced T3. This is involved, this is distant more than 5 millimeters from the mesorectal fascia. This is actually involvement of mesorectal fascia. This is actually very important to differentiate. The surgeon doesn't call you if you miss, oh, there's a 2 millimeter tumor inside the mesorectal fascia. But if you miss this, they're going to call you. This is very important to call, like, not to miss, because there's a high risk of recurrence. So make sure that you don't miss a tumor that's advanced and it's involving the mesorectal fascia. So identify your mesorectal fascia, and also remember, there's no, when you go high rectum, there's no mesorectal fascia. Anteriorly, there's peritoneum. So if you see this appearance anteriorly, that will be actually T4 stage, so not T3.
Okay, thank you.
Sure.
There was just a question about clarification for the relation between tumor invasion, but I think Amir just did it. I have another question from one of our audience. Want to know how you put up your report while doing restaging after CRT. Do you just use previous stage and add whatever the response of treatment is, or use a totally different restaging?
Yeah. So if you follow the Society of Abdominal Radiology, SAR, website, or I think RSNA probably has some templates for rectal cancer staging as well. They actually specifically, I think SAR one is the best one for the structured reporting. And if you look at that in the body of the report, you're going to use the same descriptors, meaning that if is the tumor, like how far it is into the mesorectal fascia, fat, how far it is from the fascia. But then ultimately, at the end, we are not going to use a new T stage. We're just going to say either complete / near complete response, or we are just going to say incomplete response. So it's actually a dual, either positive or negative, meaning that you're just going to say this treatment was helpful or this treatment wasn't helpful. And when I'm restaging, I always look at the pre-treatment exam. I look at the line, the diffusion weighted imaging, and I look at the T2. So you're going to see the tumor that was, bright on T2 and heterogeneous, it just gets replaced by fibrosis, which is T2 dark, meaning that similar to here is a very good example of it. But sometimes the response is not as obvious as you see it in this case. So sometimes you see a little bit of tumor is still there. You just say in near complete with some residual viable tumor, something like that. I just change it a little bit. I want to tell them that there's a little bit of tumor still there. What does it mean? It means that I want them to continue with chemoradiation for another period and then come back and do this restaging, meaning that the treatment wasn't enough, give it enough time, give it more time, something like that. So that's the meaning for partial response. So we have either complete response, partial response, or no response.
There's some form of like a G1, G2 kind of grading for treatment response, I guess. Do you ever use that? Or
I never use actually, no, T1 or T2. I actually don't restage. We are not supposed to give restage the T, because whatever the patient was at baseline is it's going to stay the same. We're just going to say it was a 3-3 stage. Now it is responded to treatment and it's completely gone. So what does it mean? It means that there was a T3, there was involvement of like structures around the tumor, around the rectum, but now it's replaced by fibrosis, meaning that they still have to go after that fibrosis, because that there might be a tiny amount of tumor there, But if you do, now if you say like T3 is now T2, you might not be accurate. You don't know if there's still tumor inside the mesorectal fat. You're just going to say it's responded based on imaging. We don't know how much tumor there is still. So if you don't give restage the T stage. Does it make sense?
Yeah, absolutely. So I think we are about to end our session. That was a wonderful talk and a very good overview on rectal cancer from Dr. Amir. I would like to thank Dr. Amir again. And then this will be the end of abdominal imaging for March. And then we will be joining again on our regular scheduled time like before in April. So for today, I would like to end the session for now.
Thank you very much for having me, and best of luck to you, and hope we can work together in the future.
Thank you, Amir. Thank you very much.
Thank you very much. Bye.
Okay, bye.